Hello, my name is Dr. Dewan S. Raja. Today I will discuss about diabetic ketoacidosis. The diabetic ketoacidosis or DKA is a serious and potentially life-threatening complication of diabetes mellitus. It primarily occurs in individuals with type 1 diabetes, but it can also affect those with type 2 diabetes in certain situations. Diabetic ketoacidosis develops when there is a severe shortage of insulin, leading to an increase in blood glucose level and the production of ketones. Diabetic ketoacidosis is characterized by hyperglycemia, that is increased level of glucose in the blood, ketonemia, there will be ketone body in the blood, and there will be metabolic acidosis that is compensated partly by respiratory alkalosis. Pathogenesis of diabetic ketoacidosis, insulin deficiency. DK is commonly associated with a lack of insulin, which may result from not having enough insulin in the body or from factors that reduce the effectiveness of the available insulin. Hyperglycemia, another condition that happens in diabetic ketoacidosis. The blood glucose level rises significantly, leading to excessive thirst, frequent urination, that is polyuria, and dehydration. Ketone production. In the absence of sufficient insulin, body starts breaking down fat for energy. This process produces ketone. Because body cannot use carbohydrate, so there will be breakdown of fat for energy. So these ketones are acid byproduct. Like we have acetoacetic acid, acetone, beta-hydroxybutyric acid that can accumulate in the blood, leading to a drop in blood pH. So pH will be decreased. There will be metabolic acidosis. Acidosis, the accumulation of ketone body in a condition known as acidosis, where the blood becomes more acidic than normal. This can lead to a range of symptoms including nausea, vomiting, abdominal pain, and altered mental status. Certainly a lot of fatigue. Almost patient feel no energy. Common triggers for diabetic ketoacidosis. What are the triggers? Okay. Illness or infection. Infection or other illnesses can increase the body's demand for insulin, leading to a relative insulin deficiency. Missed insulin doses. Skipping insulin injection or not using enough insulin can contribute to the development of diabetic ketoacidosis. Stress or trauma. Physical or emotional stress can trigger the release of stress hormones which counteract the effect of insulin. Inadequate diabetes management. There is a trigger for diabetic ketoacidosis. Is one of the triggers like these all. Poor management of diabetes, including inadequate monitoring blood glucose level and failure to adjust insulin doses appropriately, can contribute to the risk of diabetic ketoacidosis. So what are the clinical features of diabetic ketoacidosis? Symptoms include nausea, vomiting, fatigue, abdominal pain, polyuria, increased frequency of urination, polydipsia, too much thirst, and altered mental status. Physical examination is cusmal respiration, rapid, shallow breathing. This is a way to compensate metabolic acidosis. There will be an attempt to have respiratory alkalosis. There will be acetone breath or fruity breath because the ketone, one of the ketone component acetone, is released through the air. Okay, dehydration may be reflected by hypotension, reflex tachycardia, dry skin, dry mucous membrane. Differential diagnosis of diabetic ketoacidosis include hypoglycemia, non-ketotic hyperosmolar coma, isopropyl alcohol ingestion, alcohol ketoacidosis, lactic acidosis, uremia, toxin ingestion, and starvation ketosis. So let's go to the lab values to diagnose diabetic ketoacidosis. Blood glucose level, markedly elevated blood glucose level, often exceeding 250 mg per 100 ml, that is 13.9 millimole per liter, and sometimes much higher. Ketone bodies, presence of ketones in the urine and elevated blood ketone level. Ketone bodies include acetone, acetoacetate, and beta-hydroxybutyrate. Usually acetoacetate is assessed. We may also assess beta-hydroxybutyrate. Blood pH acidosis is evident with a decrease in blood pH. Typically pH below normal range 7.35 to 7.45. Suppose it is 7.1 or 6 point something, maybe 6.11 in very rare condition. Bicarbonate level, reduce serum bicarbonate level below 18 millieq per liter due to accumulation of ketoacidosis. Other lab values like anion gap is elevated. This is calculated using the formula anion gap equal to sodium plus chloride, sodium minus chloride plus bicarbonate, and an elevated anion gap is characteristic of metabolic acidosis in diabetic ketoacidosis. So there will be an elevated anion gap that is measured between sodium value is minused by chloride and bicarbonate. Electrolyte imbalance, depletion of potassium despite total body store being elevated due to urinary losses. This can sometimes lead to life-threatening complications such as cardiac arrhythmias. Sodium level may be normal or slightly decreased. Blood urine nitrogen, BUN, and creatinine, elevation of blood urine nitrogen, and creatinine indicating dehydration and impaired renal function. Serum osmolality, increased serum osmolality due to high concentration of glucose and ketone in the blood. Fluid status, dehydration is often present, leading to increased hematocrit and blood urea nitrogen. C-reactive protein, elevated CRP, may be observed in response to inflammation or infection, which can be a triggering factor for diabetic ketoacidosis. Treatment of diabetic ketoacidosis. We need fluid replacement because there is dehydration. Intravenous fluid, it may need 5 to 10 liters depending on the situation and status of diabetic ketoacidosis and also body weight. Okay, so intravenous fluid should be administered to correct dehydration, improve blood volume. Fluid also helps to dilute high blood glucose level. Normal saline 0.9% sodium chloride, that is isotonic, is commonly used for initial fluid replacement. This 5 to 10 liter initially start at 1 liter per hour depending on the situation. Insulin therapy, regular insulin is administered continuously through an intravenous infusion. Insulin helps to lower blood glucose level and inhibit further ketone production. As blood glucose level decreases, the shift from a catabolic to an anabolic state occurs, reducing ketone production. Electrolyte replacement. Diabetic ketoacidosis is associated with electrolyte imbalances, particularly low potassium level, hypokalemia. Potassium replacement is essential to prevent complications such as cardiac arrhythmia. Monitoring of electrolyte levels, especially potassium, is crucial during treatment. So, fluid, insulin, electrolyte replacement. We are continuing on treatment. Correction of acidosis. Administration of insulin and fluid helps correct the metabolic acidosis associated with diabetic ketoacidosis. Bicarbonate therapy is generally not recommended for routine use and is reserved for severe cases with very low pH. Identification and treatment of precipitating factor. Identifying and addressing the underlying triggers for diabetic ketoacidosis, such as infection or missed insulin doses. It is important for preventing recurrences. So we must take care of the precipitating factor. Monitoring and supporting care, regular monitoring blood glucose, ketone, electrolyte, and other vital signs is crucial during diabetic ketoacidosis. Patient may require close monitoring in an intensive care unit setting, especially if they have severe acidosis or other complications. Transition to, we'll go to that. Okay. Transition to subcutaneous insulin. As the metabolic abnormalities are corrected and patient conditions stabilize, transition from intravenous infusion to subcutaneous insulin can be initiated. This transition is typically done once the patient is able to tolerate oral intake and ketosis has resolved. So we initially use intravenous fluid, we use the intravenous insulin, but eventually we will switch to subcutaneous insulin, which can be taken by the patient himself or herself. Okay, must monitor everything. Okay, so it is a very difficult situation. So we got that. Now prevention and disposition of diabetic ketoacidosis. Prevention, information and education for the caregiver, maybe day caregiver in children, maybe school facility, teacher, family member, and to the patient. Everyone need information and education. Disposition, average mortality rate is 5% to 10%. In children less than 10 years, diabetic ketoacidosis causes 70% diabetes-related death. Cerebral edema occurs in around 1% episodes of diabetic ketoacidosis in children and is associated with a mortality rate of 40% to 90%. Okay, and that's all about the diabetic ketoacidosis. If you have any question, please feel free to ask me. Please share the information with your friends. Please support my channel. Please subscribe me. Have a nice, wonderful and blessed day. Bye now.